All right. Well, hello, everybody. Hopefully, you all can hear me okay. Let me know if you can't. My name is Diana Isaacs. I am a clinical pharmacist and a diabetes care and education specialist. And I also coordinate the CGM program here at the Cleveland Clinic Diabetes Center. And so, what I'm going to talk about during this, I guess I have this whole hour, is continuous glucose monitoring. And I do have a lot of questions I put in throughout, so hopefully you can use the chat to answer the questions, and then we should have plenty of time at the end also to where you can ask questions, and I'd be happy to answer those as well. So this is what we're going to plan to talk about here today. We're going to introduce CGM. I don't know all of your backgrounds, so some of you may be wearing CGM. For some of you, this could be your first time hearing about it. So we're going to introduce it. We're going to talk about what impacts blood sugars, what all those numbers mean, whether you're doing finger sticks or you're using CGM, what those numbers and that data means, and then specifically some of the challenges and solutions to using CGM, and then the question and answer. So in terms of what does a CGM do, it actually measures blood sugars every 5 minutes. And so if you do the math, that's actually 288 blood sugar readings a day. So even if you are one of those people that's doing a lot of finger sticks, and let's say you're checking 4 times a day, or even if you were checking 8 times a day, this clearly is providing a whole lot more information. And the nice thing about it is it really, you can really learn when your blood sugar is going high, when it goes low. There's also arrows letting you know the direction it's going. Because we know a 150, for example, if that's going up, that's very different than if a 150 is going down or if it's just steady at 150. So it really allows you to get an insider look into how food, medications, physical activity, stress, all those things affect your blood sugars, with the goal of just being able to stabilize your blood sugars more and keep those in steady range. So we have some different parts to CGM. We have a sensor, a transmitter, and a receiver. And so the sensor is actually in this picture on the left, and that goes just beneath the skin. You can see it's bendable. So I like to think of it like an eyelash. It's not, there is actually a needle that initially goes in, kind of like when you prick your finger, but that needle doesn't stay in. It's this tiny little sensor that stays just underneath the skin, and that is sensing that blood sugar level and then communicating that to a reader or a receiver. There's also that transmitter. So the transmitter is that part on the outside. And depending on the type of device you use, some of them, like the one on the right, the transmitter and the sensor are all together. The one in the middle requires a separate step of attaching that transmitter. And in that case, the transmitter is reusable versus the one on the right. That one is just disposable. You toss it away when you're done and you put on a new one. So depending on the device, it's worn anywhere from 7 to 14 days. And many of them are approved to replace finger sticks. So to be able to make treatment decisions, such as treating a low sugar or basing your insulin dose off of that reading. So I really like this visual to demonstrate the difference between BGM versus CGM. So BGM would be like your typical finger sticks from your meter. And this is actually showing an example. There's 4 dots here. So a person that's checking 4 times a day. And that green represents that target range that we're trying to stay in between. And we'll talk more about that in a little bit. And this is a 24-hour period. So if I just looked at those black dots, I would say, okay, this person appears to be in range the whole day. They must be meeting their blood sugar targets. But actually what's happening in this example is overnight, the person's actually going low. And during the day, we can see there's times where the person's going high. And so we wouldn't know this unless the person wore a CGM to be able to see this additional information. So I have a couple questions for you. My first one is, what types of things raise your blood sugars? And hopefully we can use the chat feature to be able to talk about that. What kind of things you guys think raise your sugars? I guess you could probably either put it in the chat or even the Q&A. Don't be shy. I'll get us started. So when we think about what kind of things can raise sugars, oh, good. I'm starting to see some now. Thank you. So stress, of course, stress can raise blood sugars. Absolutely. I'm seeing food, high carb food. Absolutely. Candy. Yes, candy would be a higher carb food. That would definitely raise the sugars. Infection. Yeah, candy bars, absolutely. All those things can raise it. Rice or quinoa, yeah. Anything that has carbohydrates in it can for sure raise those blood sugars. What about what kind of things drop blood sugars? And I saw asthma meds. Yeah, certain medications can raise sugars too. So certain steroids can raise blood sugars. So in terms of what drops, I'm seeing exercise can drop. Someone put crying and grief. That is probably one that could go either way, depending on how that uniquely affects you. Exercise, right? Someone's putting stress may lower them. Okay. And insulin. Yeah, absolutely. Right. Insulin, the medications that you take for diabetes are expected to lower them. I'm seeing a person put sleep, alcohol. Yeah, alcohol is very interesting. That usually does lower blood sugars. Unfortunately, alcohol does so in a way that is it's not predictable. So unfortunately, you can't use alcohol as a way to lower your sugars because that can cause you to drop too low. But that is one of the dangers we worry about is too low sugars with alcohol. And I'm seeing sleep apnea. So I'm seeing a hand raise, and I don't know what to do about that, but and not eating. Yeah. So let's go ahead and explore this some more. This, if you haven't heard of Diatribe, it is an amazing, amazing resource. It's a website that has tons of very good information, and it's very accurate and very up to date on all the new technology in CGM. But Adam Brown, one of the previous writers for Diatribe, talks about how there's at least 42 factors that affect glucose and food. So we talked about some of those carbohydrates, and the thing is, there's a lot, we actually know that some of the other parts of food, sometimes the protein, the fat component sometimes has a delayed effect and can raise the sugar a little bit later. But carbohydrates are certainly the main source that can raise sugars the most. But I want to point you, because these arrows represent if it goes up or down. And you'll notice in some of the cases, the arrows go up and down, they go sideways. And so one of them I want to point out to you is caffeine. So caffeine, for some people, it raises them, and for some people, it has no effect. And so if you think about like something like a cup of black coffee that has no sugar, no cream, nothing in it, and learning how does that affect you. Some people actually need insulin for black coffee because it spikes them up, and other people have no effect. And that's where something like CGM is so useful, because you learn what uniquely affects you and how you respond. For example, something like a sunburn could raise somebody's blood sugars, but someone else might not have such an effect. Exercise is very interesting. So yes, typically, if you were to go for a walk after eating, we would expect your sugar is going to go down. And so that's one of the things we recommend after eating. But sometimes intense activity, like, running really hard or lifting weights, that sometimes will initially raise the blood sugar, and then we might see a drop hours and hours later. So the point is, everyone really responds individually to these types of things. So I wanted to bring up awareness about meters, because I do get the question a lot. Well, my CGM is different than my meter, and why are they different? So the first thing to know is that nothing's perfect, and meters can actually be within 15% off of the true, lab value. If you were to get your lab tested, it can be 15% off. And in addition to that, the technique that you use to collect that sample can cause it to be even further off. So this was a study with 10 people that did not have diabetes, and they had them peel an orange, a grape or a kiwi and check their blood sugar. And so when they checked it, it varied anywhere from 171 to 360. And these were people without diabetes. When they fully washed their hands, their blood sugars were all below 100. So those are pretty significant elevations. And what's so interesting is even with using an alcohol wipe, which is, what we recommend if you can't wash your hands, there was still those elevations. And so I think the point of this is really important, the technique that you use, that you have those clean hands. But we know meters are not perfect. And so we have to have that in mind when we're comparing meters to the CGM readings. So let's talk about the types of CGM, because I truly believe CGM can and should be accessible to everyone. That doesn't mean everyone with diabetes needs to wear one all the time. I think it depends what type of medications you're taking. It depends on your own unique diabetes. But for those that are not wearing a CGM all the time, there's a great option to wear what's called professional CGM. And this is CGM that's owned by the clinic and basically lent out to the person with diabetes to wear for usually 7 to 14 days. Depending on the device, it can be anywhere from 6 to 14. And so this is different from personal CGM. For professional, interestingly, most insurance plans will cover this 2 to 4 times a year. So it's a great, tool to kind of have for people to be able to do, to learn how their body responds to these things. And then, they can go off of it and then try it again in 3 to 6 months. Now, some people will choose to go and have personal CGM, where it's owned by the person and they are going to wear it all the time. But even for people that have a personal, they still are going to change it out. So depending on the type of device you have, you're going to be changing it every 7 to every 14 days. So that's something the person would do on their own. So for personal devices, there are 2 types. And maybe some of you are wearing these, some of you maybe have seen them on TV, but there's the real-time CGM, which is always giving a blood sugar reading and can alert for high and low blood sugars. Also can have even predictive alerts, like predicting that a low sugar will be coming in 20 minutes. The intermittently scanned devices are scanned by the person with diabetes. And so you don't know your blood sugar unless you scan it. But the latest version now has an option to have optional alerts. So that's where the alerts would occur, but you still have to scan it to be able to see your blood sugar reading. So these are the different ones that we have on the market. And so the ones that you scan are the Libre 2 and the Freestyle Libre 14-day. So the 14-day is what, a lot of people were using. It also has a mobile app. So some people will use their smartphone instead of the reader. The Libre 2 recently came out in the last couple or few months. This one does not have a mobile app yet. So if you use it, you have to use the reader. But one of the very nice things about it is that it has those optional alerts. So you can customize that and set where you want your low alert to be. And for example, if you set that for 70, it'll go off at 70. Or if you set it at 80, if you hit that number, it's going to go off at 80. Now, Senseonics Eversense is very interesting. That is the only implantable CGM device. And so that's implanted into the upper arm. And there is an outside transmitter that you change out every single day. Currently, it's approved to wear for 3 months at a time, although in Europe, it's approved for 6 months. And I know the company's working on expanding that to 6 months in the US, or even looking at a year. That I would say the popularity of that has really declined due to COVID. And for a period of time, we weren't having people come into the office for this procedure because it is an in-office procedure. But some people really like the idea that, the sensor is inside. You don't have to change it out on your own. And it's easier to kind of detach and just take that transmitter off versus wearing it for 7 to 14 days at a time. And then the Dexcom G6, so that's a real-time CGM. It does, both the Libre and the Dexcom do not require what's called calibrations. So you don't need to do finger sticks. It completely can replace finger sticks. And this has the real-time alarm options, and also the Guardian Connect also has the real-time alarms. the Guardian Connect does require calibrations. And there's another Medtronic called the Guardian 3, and it's almost identical to the Guardian Connect, but it's the version that's compatible with their insulin pump. So these are what we have on the market now. There's a lot of growth in this area, and likely we are going to see more versions coming in the near future. So this image is showing what real-time data is all about, that you see the number, but it's not just the number. You have those arrows letting you know. And for example, this picture here of the 108 with the arrow going down, I would look at that and say, whoa, I've got to eat right now, because that means it's going down quickly. Versus, if it's in the 202 and the 112 examples, you can see it's actually rising a little bit. So that would alert someone that they should probably recheck it in a little bit to make sure it's not rising a little bit too much. And then you could also see a horizontal arrow like the one in the middle, just letting you know your blood sugar is pretty steady. In addition to those arrows and that number, you also see this trend line letting you know, over the last few hours, where has your blood sugar been? And that's nice to be able to see in case you weren't looking at it at that time or scanning it at that exact time. So what do these arrows mean? Well, depending on the type of device, we'll tell you exactly what it means. But generally, you could see an arrow going up, an arrow going down, an arrow sideways, double arrows up, double arrows down. And so what it means is, if you've got an arrow going up or down, it's usually increasing or decreasing by 2 to 3 points a minute. And the way I like to think about that is that in 30 minutes, your blood sugar could be 60 to 90 points higher or lower. And so that's super helpful to understand when you're making decisions about how to treat your sugars or, what to eat. I think having that knowledge can be really, really powerful. And then we are seeing so much integration now. This is what it looks like. So we have these things called smart pens, which are these connected pens that can actually help you to calculate insulin doses and record the dose of insulin that you took. And the neat thing about this is the reports can actually show your data with all of the insulin data, and if you're entering in carbohydrates, that type of data, and it's all in one report. And so you could work with your healthcare team to really go through those reports and adjust your diabetes treatment based on kind of meeting your glucose targets. So what can you expect from CGM? I think training and education are really important, even though these devices are not that hard to set up. To really make the most use of it, you want to learn what all the information actually means. So what I always advise people is that, you're going to see numbers that are different than what you're used to, because most people are usually checking, before they eat or before bedtime, but you're not seeing exactly what happens right after you eat. And so you may see numbers that are higher than you've seen before. It's also possible that you could see numbers lower than before. You may, depending where you set your alerts, and if you have a device that's alerting, you could get alerted for high and low blood sugars. And so I always use this as a time to review the basics of diabetes. How should you treat a low blood sugar? If your low alarm goes off, what do you do? And so we always recommend the rule of 15. That is 15 grams of fast-acting sugar or carbohydrates. And that would be something like half a cup of juice or soda, 3 to 5 pieces of candy, or 3 to 4 glucose tablets. And we have in here not chocolate. Anyone know why we might say not chocolate? So the reason for not chocolate is chocolate has fat in it, and it's going to delay how quickly the blood sugar rises. And so when you're trying to treat a low blood sugar, you would want something that's really going to make it rise as quickly as possible. And that's the time when you want juice or soda. Normally, if your sugar is not low, we don't encourage juice or soda because it will make your sugar rise too quickly. So can you prevent a low sugar? Well, yeah. So we saw in that previous example, the person was 108 and the arrow was going down. So absolutely. But the way that you prevent a low sugar might be different than the way that you treat a low sugar. In this case, we'll usually recommend a more wholesome snack, something that has some protein and fat in addition to carbohydrates. And I included some examples on here, like peanut butter with an apple, cheese with whole grain crackers, celery with hummus, or half a sandwich on whole wheat bread could be some good options. So next, what we're going to go ahead and talk about is viewing the data and what it means. And when I do this, I always like to talk to people about the fact that these are numbers. So it's not good or bad. You know, some people, they're scared. They're like, oh, I'm afraid to look at the data. I'm afraid it's going to be really bad. And there's no such thing as bad data because it's just numbers. And we're just using that information to be able to, help you to achieve your glucose targets. And the good news is we don't expect perfection. The guidelines don't expect perfection. Nobody needs to be perfect. So as we go into what the data means, I have some questions here for you that I think are important to go over so you understand what CGM data means. So first of all, what is an A1C? Who can tell me what an A1C is? So let's see. Okay, so I'm seeing measure of blood sugar level. Okay, so typically we usually say that yes, an A1C is very good. So we've got some 3-month average of your blood sugar. Absolutely. So that's what we say. Yeah, I'm seeing more of those. Good. So I find a lot of my patients understand, like they know what A1C is, and this is great. So 3-month, average of your blood sugar, great. And what is your A1C target? So who here knows what their A1C target is? So I'm seeing 7 and lower. 7 or below, okay. And just so you know, this is individualized. So for a lot of people, it's going to be under 7. For some people, it's under 8. In other people, we have it individualized. So question, for all those people that are saying 7%, what does that mean? If you're achieving an A1C of 7%, we said that it's an average of your blood sugar, an average of what? What does that mean your blood sugar is averaging? Any idea? I'm curious if anyone knows this. I suppose you could Google it too, but so I find that a lot of people don't know this. I find that so I'm seeing around 150, which is right. It is actually 154. I find that most people don't know that a 7% A1C is 154. And it's not so important that you know it's exactly 154. 150 is fine. But I find that there's a disconnect between people are told, oh, well, you should have an A1C of 7, or you should have an A1C of 6.5 or 8, whatever your individual target is. But they're not told what that actually means. And so you're going to get your lab done and you're just like praying that your A1C is at that target, that magic target. But it's helpful to understand what that actually means and how it compares to your blood sugar goals. So knowing that your target is perhaps trying to average 154, to me, what that would say is that, at certain times of the day, you're going to be below 154. And at other times of the day, you're going to be above 154. But the idea is that you're going to be overall averaging around 154. So with that, what do you think happens to blood sugars after you eat? Or I should say after you eat carbohydrate. So the answer is that it goes up. And that might sound really simple, right? I'm saying they rise, right? They rise. And that's the right answer, but that's important to remember. It is normal for blood sugars to rise when you eat. That happens even in a person without diabetes. So don't beat yourself up when your blood sugar rises when you eat. We don't expect a flat line. A flat line means dead. You don't need a flat line. It is normal for blood sugars to rise when you eat. It's just a question of how much. We're trying to limit how much it goes up. But of course, there's going to be a rise when you eat. So in general, I'm seeing the question about, does that mean each 1%? Yes. So generally, like an A1C, for an example, an A1C of 8% is an average around 184. So it is it's very close to a 30-point difference for each A1C change. So let's go ahead and let's review these blood sugar targets. So I'm seeing reason to not check within an hour or two. So let's review the blood sugar targets. So yes, for a lot of people, that A1C goal is to be less than 7%, although again, it really should be individualized. When we're aiming for a goal of less than 7%, that means that before meals, we're aiming for a target of 80 to 130. And after meals, we're trying to keep it under 180. So really the idea is that after eating, you're trying, of course it's going to go up. You're trying to maybe keep it around a 50-point increase that it goes up. So it's not, it actually, we do encourage some people to check. Usually we focus first on the before meals and try to get those to target. But once we get those to target, we try to see if we can help you achieve those goals after meals too, to see if you can keep it under 180. So what happens when blood sugar goes below 70? What's it called? And how do you feel? Blood sugar's under 70. Hypoglycemia. Okay, great. Right. So when it goes below 70, it's considered to be a low blood sugar or hypoglycemia. And typically people don't feel very good. And it also can, lead to just unpleasant symptoms, feeling dizzy, feeling lightheaded. I'm seeing shaky, confused, could be difficult to think. You could feel irritable, sweaty, seeing out of it. Right. So we're trying to avoid blood sugars under 70. And I'm seeing sometimes you don't notice. Yeah, that's another, huge advantage of CGM, because some people don't feel the symptoms when their blood sugar goes below 70. So I want to introduce to you this could be a new concept. If you don't wear CGM, this may be a newer concept for you. It is called time in range. And this is really a newer area that we're adding, instead of just focusing on that A1C level, looking at what's called time in range. So let me kind of explain it to you and where we got this and what all of this means. So this is showing a picture of a 24-hour period, and it's going from 12 a.m. to basically to midnight. And this is the line showing where this particular person is averaging. The target range is set for 70 to 180. And so you may be asking, well, why? Why is that the target range? So we're trying to keep blood sugars above 70 because we're trying to limit low blood sugar or hypoglycemia. And we're trying to keep the blood sugars under 180 because that's the recommendation from the American Diabetes Association, that after eating, a person should try to keep it under 180. So in this particular example, this person is 17% in that target range based on their CGM data. So going back to A1C, one of the big problems with A1C is that it is just an average. And so I like to think of the analogy, if I were to put one foot in ice cold water and the other foot in boiling hot water, you could say the average of my feet is room temperature, right? But my feet feel terrible. One is so hot, one is so cold. That doesn't feel good, but technically it's room temperature. Well, it's a similar concept with A1C. You could, be high half the time and low half the time and have an A1C at target. And sometimes we see that people are just having tons of low blood sugars, and that's what's bringing their A1C down. And we know that's not really healthy. Just because your A1C is under that magic number 7, if you're having a ton of highs and lows, that is just not going to be healthy. So that's where this time in range is really such a great concept, because we're not just looking at an average, we're looking at the amount of time you spend in this range. And what we've learned is that the more time in this range, generally the better people feel, because you're not feeling those symptoms of low sugar and those symptoms of high sugar, and also the better chance of just having good outcomes and not having any of those potential diabetes related complications. So this provides kind of an overview of what those different CGM key metrics are. So this is showing again that 70 to 180 is that target range. But then we also, when we look at your data, we're also looking at the amount of time you spend in low blood sugar, and that's called the time below range. And then we're also looking at that time you spend above range, that time you spend over 180. So we have some additional things on here. The data sufficiency is the number of days that you wear. And when we download the reports, we're actually looking to have 14 days worth of data with at least 14 days of data with at least 70% of it worn. All that means is that you've either, if you're using a scanning device, that you scan it regularly. And if you're using another type of device, you need to be close enough to your receiver to be able to pick up that signal and be able to wear it. I always tell people, though, if you're not wearing it that often, it's okay. We still can look at your data. It just means some of these metrics like time and range might not be as accurate because we don't have the full picture. There is something else on here called Glucose Management Indicator, or GMI, and that is an estimate of your A1C based on that average. So a lot of people like that because let's say you just had an A1C drawn a month ago, and we know usually you have to go ahead and have that done every, you can't get it done any more than every 3 months. But you'd be able to look at the GMI on your report and see, is your A1C improving, and what's your progress with the A1C? And then there's also another marker that just gives us information about the variability on there. So I'm seeing a couple of questions, which I'll go ahead and address. So A1C, why the percent? Can you briefly comment? What is the context of a percent? So basically with hemoglobin A1C, it's the amount of hemoglobin that's glycated. So it's basically the glucose percentage that is on those red blood cells. And that's really where it's coming from. And so the higher the percentage means there's more glucose on that hemoglobin. And actually one of the reasons it's 3 months is because the lifespan of a red blood cell is about 3 months. So that's why typically we don't recommend getting it drawn more than that, except maybe like in pregnancy. And then I'm seeing the question, why do some renal patients have a low hemoglobin A1C even though they are not? Okay, they are not compliant. This is not me. Okay, so that's a good question. And I didn't mention this, but it's a very good point. A1C is not always accurate. There are several conditions that can falsely elevate or falsely decrease. And so one of them is with chronic kidney disease, like you might see in someone that's, getting dialysis, or other chronic conditions or things like anemia that affect the red blood cells that can actually cause the A1C to be an inaccurate reflection of the average glucose. And that's another plug for CGM, because if you ever have that situation where, someone does those finger sticks and those finger sticks seem so different from what that A1C is, that's a great opportunity to use CGM to see maybe what's really happening in that situation. So, this is a good question for you guys. So we talked about how the time in range, the target is 70 to 180. How much time do you think it's recommended to be in that 70 to 180 range? Do you think it's, 50%, 70%, 90%, or 100%? So I'm really curious your thoughts on this one. So I'm seeing 90%, a 70%, a 100%, a 70% again, 50%. So I feel like this is a good question because like when I initially heard about this concept, I thought, well, wouldn't we want to be 100%, right? Like we talk about how the goals are, to avoid hypoglycemia and we want to stay under 180, but actually the goal is not 100%. And what we've learned with CGM is that, of course, there's going to be times when people are not always in that 70 to 180. It's a goal to strive for, but it doesn't have to be perfect. The guidelines actually recommend 70% or more for most people with diabetes, and actually for people that are higher risk of low blood sugars, or maybe people who are a little bit older or who have a lot of other medical conditions, the goal is to be 50%. And for me, I feel like this is really good news because it's really achievable. Saying that you have to be 100% or 90%, that's like kind of scary. That sounds impossible. But knowing that the goal is for you to be 70% in that range or even 50%, I feel like that's really achievable. And that's what we're asking. And you might be wondering, well, why? Where did those numbers come from? 50% time in range actually correlates very well with an 8% A1C. And 70% in that range correlates with a 7% A1C. So the idea is that if you can achieve those time in ranges, you are doing your best job of being able to live your healthiest life and not have any potential diabetes complications. So this is just visualizing, showing what these targets are. So for type 1 and type 2 diabetes, that greater than 70% for most people. And we're trying to minimize the low blood sugars to less than 4% of the time and minimize the high sugars to less than 25% of the time. So yes, to the person before that said, don't check after eating because it might be high. So I would say, yes, you can check, but if it's high, don't stress about it. It's okay. Sometimes it's going to be high. And our goal is to figure out what we can do to just try to get it more in range. And then you can see here for people who are older or at higher risk of low sugars, our goal is to really minimize low blood sugars to less than 1% of the time. And then the one time when that target range should be changed and not be 70 to 180 is in pregnancy. That is the only time where we change that target to 63 to 140. And that's just based on stricter criteria in pregnancy. But you'll notice, even in pregnancy, we're aiming for 70%. So I always tell people, people, especially pregnant women, stress a lot because they obviously care a lot about their baby. But I tell them, don't stress. We're aiming for 70%. That's doable. That's like a C. We can do this. This is what an ambulatory glucose profile looks like. And if you end up, looking at your data, if you download your data or you have it downloaded in the office, this is usually what we look at. And this is my favorite way to look at the data because it's all in one page. With this data, it is possible to print out 20 pages or, lots of pages. And some people might like looking at that, but this is a way to really kind of condense everything into one report. And, at the top, we have the time in range. So a person can see what percentage time in range they are and how far they are from their personal target. We see this graph letting a person know like where they're running at different times of the day. This particular graph is very, very wide, indicating this person has a lot of variability, kind of going from high to low, high to low. And at the bottom, the last 14 days, which you can also see in this particular report, that the person is having more highs and more lows. The yellows represent highs and the red represents lows. So there just may be an opportunity because I bet, if the person whose data this is may feel tired or not good all the time, because when you're going low and then you go high and then you go back low, that can be really hard to deal with. So I want to really express the importance of the time in range target when you are looking at your reports and when your healthcare team is looking at the reports. This recently happened to me. I was looking at someone's data And I saw that they were 31% in range, which is fine. And that, provides a good opportunity to start to work on, strategies to increase the time in range. But then I took a closer look and realized that their target had been set for 70 to 130. So we want that target to be 70 to 180. And so when I went back into the report to change it to 70 to 180, that person's time in range was actually 65%. So that's very, very different. And so it's important when you're evaluating your data, you want to make sure you're looking at the right thing, that you don't, I've seen some people set it for like 100 to 140, and you don't want to just be looking at a snapshot. You want to have that whole range to look at. So one of my favorite things to do is to look at the day-by-day readings and determine if we can identify patterns, causes, and my very favorite thing to do is to focus on the day where time in range was the highest and try to repeat what is working well. My strategy, instead of, nitpicking like, oh, you're high here, you're low there, well, that's not working. Let's look at what is working and try to repeat it. So in this example, if I look at these days that this person had, I can see that on Monday, June 26th, this person was 90% in target range. So that's great. That's like way beyond that 70% or even 50%. So I'd go through and I'd say, hey, do you remember what happened that day? What did you eat for breakfast? Were you working that day? What did you do? What did you have for lunch? Any exercise? How was your stress level? How was your sleep? And the idea is that we try to repeat more of that, because what happened for this person on this day seemed to work really well. And so let's try to do more of that. So data gaps. A question that I frequently get is, well, why are there data gaps on my reports? What can I do about that? So there can be a couple of different causes. If you have a system like a real-time CGM, like Dexcom or Medtronic system, there can be data gaps if you're too far away from your receiver or your smartphone. So usually you have to be within 20 feet to be able to pick up that signal. And so that could be a reason for data gaps. Another one could be, if a person took off the sensor and you didn't put a new one on right away. Maybe you waited a day, or you didn't, there was just some delay in putting it on. Those can all be reasons why you could have a data gap when you look at your data. Now with the Libre, both the Libre 2 and the 14-day, those scanned devices, you do need to scan it at least every 8 hours to avoid data gaps. The sensor that you wear can only hold 8 hours of information. And so what happens is, let's say you only scan it, every 12 hours, you're going to always have these little data gaps of like 4 hours missing. So I try to encourage people to scan it, before meals, before bedtime, when you wake up. And that way, hopefully you'll limit, those data gaps. So the arrows are so valuable and so important. And this is showing that, when you see the arrows, you can make different treatment decisions. And so what this is showing is, Kim sees a low blood sugar, it's 80, and it's that arrow down, so it's going down. And so what does she do? Well, she goes ahead and she eats an energy bar because she knows that if her blood sugar is going down like that, it could really crash and be very, very low in 15 minutes. And so she proactively eats something. Now at breakfast, she sees a 122 with an arrow going up. And so what this might mean is, if she's taking insulin before her meal, knowing that her blood sugar is going up into the meal, she may need to be able to give herself extra insulin. And similarly, if it was going down before the meal, she may need to give less insulin. And this is beyond the talk for today, but I would encourage you, if you're interested in kind of adjusting your doses based on these trend arrows, work with your diabetes educator or diabetes care and education specialist to just learn the safe way to be able to do that. So the last part of this presentation, I want to talk about some of the challenges and solutions to CGM. So one of the big ones, of course, is cost and insurance coverage. And so one of the things you can do is try to find out, if it's something that's covered on your insurance plan. One of the amazing things is, we're starting to see expanded use. It used to be CGM once upon a time was thought to just be for people with type 1 diabetes. And now we we use it for lots of people with type 2 diabetes, and we use it in lots of different situations. And we're seeing some really good outcomes from clinical trials showing benefits in a wide range of people with diabetes. So I would say find out if you do have coverage, and if you don't, you always have the option to do professional CGM, which is covered by almost all of the plans. And the other option that some people do is even do intermittent use of personal CGM. So we know the supplies can be expensive, but sometimes people will choose to wear it, a week at a time, or 10 days at a time, or 14 days at a time, to at least get that information and then go back to finger sticks and kind of go off. But of course, the greatest is if you can, be able to wear it all the time. So for alarms and settings, this is so important that it is customized to your unique needs, because otherwise it can be so frustrating. It could wake you up, all night. It could wake your partner up. It could just be a complete nuisance. So you want to make sure that your settings are really set realistically. And so thinking about what's going to keep you safe for your low, if you want to set it for 70, if you want to set it for 80, there is, with many of the systems, there's the predictive. You can put, like in this one, the urgent low soon, if it's predicted to hit 55 in 20 minutes. And then for highs, I find a lot of people think like, oh, I should set my high for 180 because that's the target. I don't recommend 180 for almost anyone, maybe in pregnancy, but that's it, because that is going to drive you crazy. So typically I recommend a much higher number, maybe 250, maybe 300. Maybe we just turn that higher number off, but it's going to be individualized. And I'm seeing the question, who needs CGM? Well, that is up for debate, I guess. But I think any person that is using insulin or a drug that can cause low blood sugars, like a sulfonylurea, like a glipizide or glimepiride, I think would greatly benefit from CGM. I think for people not on those medications, they still benefit from professional CGM to periodically see how food, medications, physical activity, stress affects their blood sugars. So I think everyone in some capacity, but people who are using insulin regularly, I think benefit more from having a personal CGM device. And then how can a patient get connected with a diabetes educator or manager? Oh, well, we have lots of wonderful diabetes educators here at Cleveland Clinic. So we would love to get you connected to be able to see one of us. We would just absolutely love that. So in terms of device placement and skin issues, so we definitely get the question sometimes, that people have different skin reactions. The question I get a lot is, oh, my device is not staying on the full, the full time. And there's actually a lot of great strategies to help it stay on that whole time. The first thing is you've got to make sure the area is clean and dry. If there's lotion or anything, then you're just doomed. But there's also some great products like Skin Tack that you can put under it to keep it stickier. And then there's products that you can put over it. So there's a lot of things that you can do. So if that's an issue, I feel like I can work with everybody on that. In terms of, where to place it. So each device has their FDA approved place to put it. And the reality is, though, in clinical practice, we often advise our patients that there are other places you can put it. So even though it may have one recommended site, such as the stomach or the arm, in real life, we know people have success in those other areas. And so that's something to talk to your healthcare team about for sure. And this is just showing those sites. So, and there's also different ages. And again, it's up to your healthcare team to decide, if, for example, a child that wants to use a specific device that's not approved and older, sometimes things are used off-label. Certainly, the sites versus being the arm or being the stomach are often things that sometimes, we change. And then this is showing in terms of making it to stick on a little bit better. So these were some of the products I was describing. So like the Skin Tack that can actually be put underneath it. There's also mastisol, and the skin tack is pretty low cost. So that's usually pretty easy. Like you can get 50 of those wipes for $15. And if you're changing it every 10 to 14 days, that's going to last a pretty long time. But there's also like these nice sim patches or Tagaderms. There's different types of things that can go over it. So I'm seeing the question here, metformin, does a person using metformin need CGM? Well, a person taking metformin is not going to be predisposed to low sugars because metformin doesn't cause low sugars. I still think there's really value in seeing how those different foods affect your sugars. So I don't necessarily think a person with metformin needs CGM or certainly doesn't need to be on it all of the time, but I do think there's great value in periodically wearing it, either through like a professional CGM. I think that can be really, really valuable. So I'm seeing here, I change mine just after a shower, always end up with lumps below the skin, shortening life of sensor. Any ideas? Well, what I would say is I would definitely troubleshoot like the area. Some people, certain areas, they don't do as well. They have more skin sensitivities with. It could be the skin right after a shower may be more sensitive. And so in this case, it may be better to wait a little bit more and not do it right after showering. And just making sure, if it was an area that previously had those skin irritation, trying to just pick a different area and starting over. Those would be kind of some of the strategies that I would start with that. And then I'm seeing the question here too. Will the doctor ever prescribe CGM for people who don't have diabetes but want to monitor blood sugar levels due to other concerns? So that's a really interesting question because actually in Europe, they just approved the Libre Sense, which is the first kind of CGM approved for, I think it's targeted for athletes. So it's for people without diabetes, but just to kind of learn how, I guess the effects of blood sugars during exercise. So yes, I could absolutely see that CGM is going to be targeted for people without diabetes. And I certainly think that there can be great value in pre-diabetes and in weight management. In my last slide, and then we'll be sure to answer all the rest of your questions, just some Cgm Pearls. So even with the devices that don't require calibration, meaning you don't have to do the finger sticks, there are still certain times where you're going to want to do a finger stick. So that would be any time your symptoms don't match the sensor value. For example, it's saying you have a low sugar, but you don't feel low. So you really should do a finger stick because technology is not perfect. And it's possible that maybe your sugar really isn't low and you don't want to start treating a low sugar if your sugar is not really low, right? Definitely during the warm-up period, if you need to make some kind of treatment decision, like you're trying to figure out how much insulin to take when you're eating or, correcting a high sugar and making dosing decisions for select devices. So technically, the Medtronic, the Guardian Connect, still requires to do finger sticks to confirm before making a dosing decision. Now, to avoid data gaps, we want to make sure that, the receiver or the smartphone is nearby and with the Libre scanning at least every 8 hours. I get the question a lot, are CGMs waterproof? So yes, showering, bathing, swimming is okay. You do just need to figure out in terms of the type of device you have, there are different standards for swimming. For example, Libre is like 30 minutes, 3 feet versus like the other ones are usually this a little bit longer. So you just have to kind of be aware of what your specific product says. And then you want to avoid with MRI, CT, or diathermy. You do need to remove them for these procedures. And then there are certain conditions where it's not FDA approved. So that includes pregnancy, dialysis, and critically ill. And you might be thinking, well, wait, didn't you just show us those guidelines for pregnancy? And I did. So it is used in pregnancy, but it is considered off-label. And generally, we do recommend that people confirm with finger sticks in pregnancy. And so you have to be aware these other conditions can really affect the accuracy. And so you would really want someone to still be doing finger sticks. And if you're using it, it is considered off-label in that scenario. So that is what I have. I'm going to make sure I address all of your questions now. So I'm seeing for the Libre 14-day sensor, does the Libre needle get contaminated if skin is covered with skin tack? So no, that's a really good question. So the manufacturers of the Libre say that you can just put the skin tack and you can just insert it right over it. This is different than what we are told for the Dexcom. For the Dexcom, and I believe for Medtronic, you want to kind of make a little donut where you don't insert it directly through the skin tag. So that is going to differ depending on the type of device. And then I'm seeing, is the Dexcom G6 have the alarm for low blood sugars, and what is the name of this version? So the Dexcom G6 does have an alarm for low blood sugars, and there is, if you're using it on your phone, there's a G6 app that you would download, and you can customize those alerts. And then you also, there's another app that goes with Dexcom. It's called the Clarity app. I like that one a lot because that one actually, it like tells you your time in range. First of all, it automatically will connect your data to like your clinic's data, which is amazing. But also it'll send you, you can set it up where it'll send you like weekly reminders, letting you know like what percentage of time you are in range. And that stuff like that can be kind of helpful and motivating, I think. So, and I'm seeing a couple questions in the Q&A. So it says, my counts are usually around 160 to 180. With metformin in the morning, and okay, and my morning counts are high like this. My counts after 2 hours of a meal is usually around 110. So I think, you know, what I would recommend is to really probably meet with a diabetes educator, a diabetes care and education specialist. There's definitely different reasons why people have fluctuations throughout the day. Sometimes you need med adjustments, sometimes, you know, adjustments in physical activity. It is a very common thing in diabetes where people do wake up a little bit higher in the morning. And that's because the liver is producing sugar overnight. Metformin is actually one of the drugs that really helps counteract that. And so I would say, you know, you could work, but no, the question is, this serious diabetes? No, I mean, all those numbers are under 180. I think we can work with you if you want to have, you know, numbers in a different range, we can work with you on that. But no, I think I wouldn't be concerned. And then what's the estimated cost of Freestyle if insurance does not cover? So that's a great question. So if you have commercial insurance, meaning you don't have Medicare or Medicaid or like a government plan, there's a manufacturer program that automatically gives a discount to make it not more than $75 a month. Now, if you don't have that, like let's say you have Medicare, but you're going to, you know, pay out of pocket because your insurance doesn't cover it, the full retail cost is about $122 a month. Now, there are some coupons like things like GoodRx where you can look online and, you know, often you can find a better deal where, you know, depending on like what pharmacy where you can get it for a little bit less, but that's generally the cost. And the Freestyle Libre is the cheapest CGM, or I should say it's the lowest cost CGM. The other ones, like the Dexcom's a little bit more, there's that reusable transmitter that you need to replace every 3 months. And so the cost and the sensors are a little bit more. So that one just tends to be a little bit more expensive. So let's see, is metformin safe? So yes, I think metformin is safe. It's our first line drug for diabetes. My daughter has a new t:slim pump and Dexcom, and she hasn't activated. What is needed to get assistance? So I would say contact our organizers, but we would love to get you set up with a diabetes educator for that pump training. We do, you know, pump trainings here, and we're very familiar with all of the technology. So we'd love to, you know, you could always call the diabetes center to schedule an appointment. So we'd love to have you do that. And then I'm seeing, why does it take so many months to obtain a diabetes educator appointment through the clinic? So I don't know, but if you call the diabetes center, I can tell you that I have availability in the very near future. I know that some of my amazing colleagues have availability and have open slots. So sometimes when you talk to the appointment center, things get a little shuffled around. So try to call the diabetes center directly and we'd be happy to help you. Oh, thank you for the feedback. I got a nice job. Thank you. That's always nice to see. And I'm trying to see if there's any questions that I missed. If I did miss your question, feel free to type it again because it's a little hard to, you know, keep track of everything. Do you do virtual meetings? Yeah, we do virtual meetings. That's been a way that we've been doing a lot of those lately because of the COVID situation. So absolutely. All right. Well, if there's no more questions, I think I've got 2:59 p.m. So I think I did good on time. Thanks again for someone else giving positive feedback. So it was a pleasure to talk to you all today. I wish you all the best and hope to see some of you in the near future here at our clinic. Thanks, everyone.